Hey students, just wanted to share some information with you about the long-term care. This is usually one of the most interesting discussions that we have besides the generations study that we do. So you've already had a chance to look over the PowerPoint about long-term care, but there are some things that I want to highlight and some things that I want to make sure that you understand. This information is very relative whether you're going into the healthcare profession or not, because the reality of it is you're going to possibly help grandparents, parents, your spouse, other family members or friends navigate through this as they age, and then you as well. So it's good to have a basic understanding of long-term care and what the payment sources are. So how do we pay for long-term care? Well, a lot of people do nothing. They just hope for the best. Many times they just kind of stick their head in the sand like an ostrich and, hope things will work out. Sometimes they rely on their family members. We know that works out sometimes, and sometimes that doesn't. Each of you have had an opportunity to think now, based on my experiences that I shared with you in those two blogs, about what you would do to take care of your parents should the need arise, or possibly your grandparents. Some of you, your grandparents are being taken care of by your parents now. The third thing that a person can do, which is probably the most responsible, is to do estate planning. And that is where you actually think about things in the future. Many times this will happen around retirement age. Sometimes younger people will do it, especially when they have children. And if they travel a lot, they will, designate who will raise their children should something happen to them. But as far as estate planning goes, that is to talk about different retirement accounts that you have, financial issues, preparing a will, preparing a living will or an advance directive. Now, the difference between those, a will is what's going to happen to your stuff, to your possessions whenever you die. In the state of Louisiana, it's forced heirship. If you do not want a child to receive something in your will, then you have to disinherit them. That sounds very drastic. Actually knew a man that did that. I guess he was married back in the 40s, and his wife left him with their two children, and he had no contact with them, even though he tried through the years. They wanted nothing to do with him for whatever reason. And then later in life, he got cancer, and he had a very successful business life. And one day they showed up. Well, guess what they wanted? They wanted to be included in that will. And he knew that, so he took appropriate measures to make sure that his current wife would receive everything that, he wanted her to have, so he did disinherit them. And, you can specify what you want in a will. If you're an only child, your parents do not necessarily have to have a will, because since it is forced heirship, then upon one of your parents' death, one half of the estate goes to the surviving spouse, the other half goes to the only child. If there are multiple siblings, then ever how many siblings, say there are 4 siblings, then a fourth of a half would go to each. Now, what most people will do is they will give the surviving parent usufruct of the finances, the property, and everything, so everything remains intact. That's, basically what will happen with that. Now, we will talk about advance directives a little bit later. Advance directive or a living will is what you want to happen if you're not able to make medical decisions for yourself, and there are several issues that arise with that. But as far as payment sources go, okay, the trend in the past for many years was when family members could no longer take care of themselves, they would be taken care of by a family member. Okay. Then as the world became faster paced and the Industrial Revolution happened and extended families moved away, there arose the need for nursing facilities. So your loved one would be put in a nursing home. The trend has switched back, is to take care of a loved one at home as long as possible. There are several different ways that can be paid for. Long-term care insurance is one of the ones. Let me just say this to you. Whenever you get out there and get your job, I'm sure your company will have a benefits package that will probably offer long-term care insurance to you. The younger you are, whenever you get long-term care insurance, the more affordable the premiums are. The older a person is and the more health conditions they have, it becomes cost prohibitive if they will even be insured for long-term care insurance. But what long-term care insurance will do, it will pay for sitters at home, it will pay for in-home care, it will pay for assisted living facilities, and it will pay for nursing home care, okay? So as I said, the trend now is to keep a person at home as long as they possibly can. So let's say mom can't stay at home anymore. Now she needs some help. She still can kind of take care of herself, but maybe need help with her meds or, with food preparation, that type of thing. And so maybe assisted living is the community that they need to be in. So how do you pay for assisted living facilities? Well, there's private pay. Long-term care insurance will pay for that, and some veterans benefits will pay for that. Medicare, Medicaid, Social Security, that does not pay for assisted living facilities, okay? I guess you could use your Social Security check to help pay for that, but Medicare does not pay for assisted living, okay? The next level from that would be a nursing facility, what we used to call nursing homes. So how do you pay for that? Well, private pay again. Long-term care insurance will pay for that. There are some veterans benefits. And, let me encourage you, if, there are some veterans in your family, like your grandfather was a veteran or your dad is a veteran, they saw active duty or reserve duty, there's a lot of different stipulations. And there are some veteran survivor benefits that go along with that a lot of people are just totally unaware of. So, check with the Veterans Administration on what the requirements are for that. But then with the nursing home, probably 90% of the residents in nursing homes in Louisiana, it's Medicaid. And basically what Medicaid is, you have to be at poverty level. The only thing that you are allowed to have to be eligible for Medicare, Medicaid is to own your own home. You can have a vehicle. You can only have X amount of dollars in your checking account if you're single. A few years ago, it was $1,999.99. If you were a couple, it was $3,999.99, but that varies from state to state. You could have a burial policy. You could not have, you could have life insurance, of course, but the things that would make you eligible for Medicaid: home, car, burial policy, and then any property that was actually connected by a corner to the homestead. Now, the homestead is the piece of property that the house sits on. So let's say, grandma, grandpa, they have 100 acres, and that 100 acres touches one corner of the homestead. Okay, well, that's not a separate asset. That's still considered part of the homestead. But let's say that 100 acres is across the road from where their house is, then that becomes a separate asset. So savings accounts, that's an asset. Life insurance, that's an asset. Those are your primary big ones. So how does that work? How does a person qualify for Medicaid? Well, there's a 5-year look-back period. They can check, the person's bank records, and if they go over that dollar amount, then that makes them ineligible for the Medicaid benefits until they spin back down under that. Now, if they do have an overage, then those things can be spent for things for the home, car repairs, anything that's being spent on that individual, okay? But it can't just randomly be spent on family members. So let's say you do the estate planning. I know when my grandmother went in the nursing home, and that's been probably 35 years ago, we didn't have the computer records like we have now, and families back then, they could just get together and say, okay, well, we're just going to split up mom's assets. You take this amount, you take this amount, I'm going to get this land, that land. Nobody could really do any check on it. Well, now everything's computerized and the federal government has access to all of those records. So in that 5-year look back period, what happens, let's say, let's say when we did it for my dad, let's say that there was $100,000 in assets. That would be property, cash, whatever. Okay. So in that 5-year look back period, if he went in the nursing home anytime during that 5 years, then it would be prorated off of what the assets were. So let's say 5 years, $100,000, that'd be $20,000 a year. So let's say we make it through 2 years, then at year 3, he would have had to go in the nursing home. That would have been $60,000 still in assets. So that money would have to be paid to the nursing home. Well, you say that's not, liquid asset right there, the land. So what would you have to do? Well, you would have to private pay until you spent down that $60,000 before the Medicaid would actually pay for the nursing home care. Now, 90% of individuals, Social Security is their main source of income. Okay, the 65 and older group. Now, their Social Security check, if they're on Medicaid, their Social Security check goes to the nursing home to help pay for their care. It depends on the state, depends on the nursing home, what allowance they're given. Most of the time, it's around $30 that they can use to, buy Cokes and other little essentials like that they may have there at the nursing home. If they want their own telephone, that has to be paid for. Used to, the TV would have to be brought in. That would be paid for. Sometimes it's now included in the price of the nursing home. So that's just kind of a brief thing of how the nursing homes work. Now, there's one other thing that I do need to mention. If it is a couple, okay, and let's say the wife needs to go in the nursing home and the husband doesn't. There's what is called the monthly maintenance needs allowance. You can't just take that other spouse's money away because they have to have money to live on as well. So there's a formula that is fixed for that to make sure that spouse that's not going in the nursing home does have adequate funds to live off of. So those are your payment sources, okay? From the start, long-term care insurance, it will pay for at-home care. It will pay for sitters. Now, sitters, that varies from state to state. Louisiana has some of the cheapest sitting rates in the country, $10 to $15 an hour for a sitter. Other states, I believe Utah has one of the highest rates that's like $37 an hour for a sitter. That can bankrupt you very quickly. Let me just give you for an example. In my blog, I told you about when my mom broke her wrist. And, I had to have sitters with her because it was her right hand. She was right-handed. And so, we were fortunate that the sitters that we had were $10 an hour. So you think about it, 8 hours a day times $10, that's $80. Times 5 days a week, that's $400. Times 4 weeks, you see where I'm going. So it becomes quite expensive. So you do need to prepare for that, but long-term care insurance does pay for that. Then assisted living, the payment sources are long-term care insurance, private pay, some veteran benefits. Nursing home is private pay, long-term care insurance, some veterans benefit. The majority is paid for by Medicaid. Now, Medicare will pay. Part B will pay, or actually Part A will pay for nursing homes in certain instances. So let me switch over to Medicare now and make sure that you have a good understanding of that. Okay, let me just kind of digress for a moment and kind of bring you up to speed with how all of this came about, because I do think it's important that you understand how things came about, okay? In the late 1800s, you had the Industrial Revolution that was happening. You had America was becoming urbanized. You had the disappearance of the extended family, and you had an increase in life expectancy, Okay, so 1935, Franklin Delano Roosevelt, who was the president, came up with the New Deal. Okay, this was social insurance that for the first time in the history of our country would provide retirement. So what did people do when did people stop working before then? Well, a lot of people worked until they died or until they couldn't, and then their families would have to take care of them. There was no insurance back there. There was no health insurance or anything like that. So basically, the New Deal um, came up with Social Security, okay, basically as we know it today, okay, but it was very selective in who was paid. It was primarily paid to white males, okay, no domestic services. Domestic services were covered, but it did cover some unemployment insurance, old age assistance, aid to dependent children, and then some medical help to the states, okay. And it's interesting to note that in 1920, more people were in the United States were living in the cities than on farms, which had not been the case prior to that. Okay, so then we come on to the Centers for Medicare and Medicaid Services, known as CMS. You'll see that a lot. Okay, 1965, Lyndon Johnson was president, and he signed into law what was known as Original Medicare, which was Part A and Part B. Okay. 1972, it was expanded to cover the disabled, people with end-stage renal disease, those people who needed dialysis or possibly a kidney transplant, and then people 65 or older that selected the Medicare coverage. Also part of that was Medicaid, okay, and this was medical insurance to people getting cash assistance. Today, it includes low-income families, pregnant women, people of all ages with disabilities, and people who need long-term care. And the states can tailor that. Now, Medicaid, well, let me back up. Medicare is federal funds, okay? Medicaid is state funds. Now, the states have to, they get part of their funding from the federal government. They get matching funds for the state funds from the federal government, but they have to meet some obligations in order to get that money. But the states can actually tailor their own programs. Then in 2003, the Medicare Prescription Drug Improvement Modernization Act came about. That provided for Medicare Advantage, Part C, which is still Medicare, and I'll explain that in just a moment. Then in 2006, Part D, the prescription drug benefit, came about. 1997, CHIP became a part of it. That's the Children's Health Insurance Program, and that was to give health insurance and preventative care to uninsured children. And believe it or not, at that point in time, it was about 1 in 7 children who were uninsured. And all 50 states and the District of Columbia actually have a CHIP program. Then 2010, the Affordable Health Care Act brought health insurance marketplace. Now, this is, it's changed some. There have been some good things that have come about with it, because one of the great things is that people who before had pre-existing conditions who could not get insured, okay, through their private insurance, this allows them to be able to do that, because as we know, everybody should have an opportunity to purchase health insurance, and it should be affordable. Not that this act made healthcare affordable through the state exchanges. It was actually quite expensive, but the premise of it was very good. But part of what they did is they did some cuts to Medicare to make up for the money, and then they allowed children to stay on their parents' private health insurance until the age of 26. I remember when my son was in college before this time, one quarter he dropped below the 8 hours because we had to verify that he was a full-time student to be covered on our health insurance. And if you drop below full-time 8 hours, then you weren't covered. Well, this was for 6 weeks when he dropped that class, and we had to buy some short-term health care insurance because, one car wreck could do you in on something like that. But now you're covered until 26, and the premise of that is that you'll be finished with grad school or post-grad school or whatever type of schooling you're going to do, and you'll have your own health insurance by that time. So it set up state exchanges where these policies could be bought. And so the premise was that when people turned 26, they would go on there and buy the insurance, or they would have to pay a penalty. Well, you think about it. When you're 26, you don't think about long term. You don't think about getting sick if you haven't been sick. And so when it comes time to pay your income tax, a lot of people elected to pay the $100, $200, whatever penalty it was for not having health care insurance, because the state exchanges, the insurance policies weren't that affordable, and it limited what doctors you could see and so forth. So that's not quite worked out, but it has had some good things. For instance, the donut hole with prescription D drugs, that has been narrowed, and what that means is when an older person who has prescription D coverage from a private source, once they spend up to a certain amount of money, then they would be what was called the donut hole. And while they were in that time frame, they would have to pay out of pocket for their medications, which we know that could be detrimental to a lot of older people, because drugs cost a lot of money. Okay, so let me see. Let me go back. I've told you about all of those different things. So now let's talk about Medicare specifically. Okay, so Part A, that's the hospitalization. That's the inpatient, home health, and then SNF units, or skilled nursing facilities. Okay, everyone gets that when they turn age 65. Okay, then there's Part B. That covers doctor visits, outpatient, diagnostic screenings. Now, that was original Medicare that Lyndon Johnson signed into law in 1965. So basically the way it worked is Medicare, original Medicare, you had a red and blue card, and it had your Social Security number on it. They've done away with that now. They've done randomized Medicare numbers, but that was the original Medicare card. And so basically the way it worked was that they would pay 80% of the allowed charges. Okay, so then that left you, or the person with Medicare, 20% to have to cover. Well, that doesn't sound like a lot, but you think about a person who maybe has had hip surgery or a heart attack or a stroke, and they've been in the hospital for a long period of time. 20% of a bill could add up. So what people would do is they would buy Medigap policies, okay? And they were private insurance policies that would cover that 20%. Many different companies like Humana, Blue Cross, Blue Shield, AARP, they sold these type of policies. Now, the only problem with those Medigap policies is they became cost prohibitive at a certain point. It was based on age, and it was based on the medical conditions that you have. Let me give you a prime example. My dad, he had a stroke back in 2008, I believe it was, 2007, somewhere in there, just a small one. And he, at that point, had original Medicare, and he had a supplement through AARP. Well, he got the bill one day, and he had some dementia going on, and he got the bill one day, and they had gone up, and so it was like $447 a month for this Medicare supplement policy. And so he thought, well, I don't need this anymore. That's just too much money, because they were on a fixed income. Social Security was their primary source of income, so he did away with it. Well, we didn't realize that until he had that little stroke. And going to the hospital, doesn't have it, so we had to pay that 20% out of pocket. And that, again, was around the time that Medicare Part C came into being, the Medicare Advantage program. And so basically what it did was privatize Medicare. Now, when a person has Medicare Advantage, they still have Medicare, okay, but the payment source is different. Instead of owing the 20%, now you only have copays. So basically how Medicare Advantage works, or Part C, is, let's say you have a company like Vantage, or a company like Blue Cross Blue Shield, or Humana, one of those, and you're going to buy their policy, okay? And they're very affordable. It's based on income. Let's say you can get one for $100 a month, and that covers everything. That has your prescription coverage, which is Part D. So now, instead of whenever you go to the doctor to use your original Medicare card, you don't give them that. You give them your Medicare Advantage card. You show that to them. You still pay your Part B premium, okay? And the Part B premium starts at $134 a month for a lot of people, and it is based on income. But you still have to have Part B. You still have to pay that premium. So now what happens, let's say it's Vantage. So Vantage goes to see mom, and they sit down, they have a nurse or, a doctor visit over telehealth or something, or you actually have a nurse that comes to your home to do a sit down with you, or you have a survey that you fill out, and they find out what all your medical conditions are, what all the medications are that you're taking, how many hospitalizations you've had. They find out everything about your medical history. And so what they do is they sit down and they figure out how much they think they can cover you for. So they give that dollar amount to Medicare. Okay, Medicare is going to actually send them that money or whatever money they agree on, and it will go into basically your account for you to use. Even though you're paying a premium, Medicare is still paying for it, but it's being administered through a private insurance company, which is really great because now, instead of having to pay 20% for everything, you have a copay that you pay, and you don't pay over that copay. It may be, $5 for a doctor visit. It may be $15 for a specialty doctor. It may be $50 whenever you go into the hospital. It may be $2 for your prescriptions, different things like that. So it's really good in that aspect. As I said, when my dad dropped his supplement, that's what we got. Never had a problem out of it. Now, I will say this, when a person goes on hospice and they have Medicare Advantage, it reverts back to original Medicare. Okay, original Medicare will pay for hospice charges. And when a person goes on hospice, that patient, that family never sees a bill from hospice. It's covered 100% through original Medicare for that. Okay, let's see, what else? Okay, and then Part D, it's offered through the private health plans. You can choose to get that or not get that. The initial enrollment period can be 3 months before the age of 65, the month you turn 65, or 3 months after you turn 65. And then you have to stay on whatever program you choose for a year. The annual election period runs from October the 15th to December the 7th. Okay, and a person can change their Medicare Advantage program during that time. They can go back to original Medicare. They can switch to Medicare Advantage, whatever the situation may be there. Now, let me talk about when Medicare will actually pay for nursing home care. Okay, now, I mentioned a SNF unit, a skilled nursing facility. Many hospitals have a SNF unit where they will actually discharge a person from the hospital, and then they just move them to a different floor in the hospital, and it's like a rehab floor. Some hospitals don't do that. Many of the nursing facilities or nursing homes have that. So if a person has been in the hospital for 72 hours, can't be 71 hours, has to be 72 hours, then they can be transferred to a nursing facility, okay? And it will pay for that inpatient hospital-based rehab facility. But the rehab has to be intensive, okay? And what does intensive mean? That means it's 3 hours a day, 5 days a week, maximum 90 days. The person has to be getting better in order to go home. Because let's say mom lives by herself and she fell and broke her hip. Medicare wants to get you out of the hospital, okay? And so, her family lives far away and they can't take off work to come take care of her. So she has to have rehab and she has to have somebody to take care of her. So she has to go into the nursing facility. And that is what a lot of the nursing facilities have gone to, is this short-term rehab where they get people back home. And of course, they do have the long-term care floors as well. But now this is Medicare paying for this, okay? And so they must, as I said, been in the hospital for 72 hours. So the first 20 days of that stay, Medicare will pay 100% of the charges. Then day 21 through 100, there's going to be a copay, and on average, it's about $170 a day, okay? Now, that is the only way that Medicare will pay for a nursing home is if it is a rehab type situation. Now, I know many of you are going to be PTs, OTs, and when we talk about Medicare, and I do hate that I did not, we weren't able to have the physical therapist come to class and occupational therapists come to class and talk to you about some of these different types of issues. I did reach out to Jeremy Johnson today to find out because I think many of you may know now that you don't have to have a script from a doctor to see a physical therapist or an occupational therapist. It's direct access now. But if you are a Medicare patient, then you do have to have a script from a doctor. And there's a soft cap of $1,980, okay, that a person can spend a year, who's a Medicare patient, can spend a year with a physical therapist. And that amount also includes speech therapy. Occupational therapy has its own separate cap of the same amount. And I think it's interesting that speech is not included with occupational therapy, where, in reality, that is where it would be, but financially it's not. Medicare is very specific when when a physical therapist or occupational therapist or speech therapist is dealing with a Medicare patient. They can't have but so many patients in the clinic at that time. There is a ton of paperwork that has to be filled out before they can even touch that patient. I encourage you, as you do your observations or you're working as a PT tech, talk to those physical therapists, occupational therapists, speech therapists about what it is to deal with Medicare, the ins and outs of all those different types of things. Okay, let's see. So that's Medicare. We've talked about Medicaid. I do want to mention the veterans benefits just briefly. Let me see where I did with my notes on that. Yes, the VA benefits. All veterans at age 65 are considered medically indigent, okay? But there are different priority groups, and it's based on specific eligibility, depending on the years that they served, if they were in active duty, if they have service-related disabilities, all of these different types of things. So there are 8 priority groups, and so once you apply for assistance through the VA, it's based on specific eligibility status. You will be assigned to a priority group. And as I said, there are 8 of those priority groups. So, like I said, that is a benefit that a lot of people are not aware that there is, especially for survivors, spouses of someone who has served in the military. Okay, so hopefully that gives you a little bit clearer understanding of how Medicare, Medicaid, Social Security all came about. Now let me go back to Social Security. I don't think I really hit on that, and I do think that is very interesting. Okay, so Social Security is paid with your FICA, okay? The FICA Act, Federal Insurance Contributions Act. 6.2%. If you work, then you'll see this on your pay stub. 6.2% is withheld. Your employer matches that. That goes into Social Security. The Medicare tax is 1.45%. Okay, so when Social Security first happened, it was basically lump sum payments that were paid out. It was interesting. The average payment was $58. The first monthly payments, or when people would get their checks in the mail, happened in January 1940. Now, to show you why Medicare got in such a bind, at the beginning, you had a lot of workers that were out there to support a few people, okay? And another reason that the New Deal came about is the unemployment rate among young people was extremely high. There were no jobs because people worked until they died. They had to. They had no retirement. And so with the monthly payment starting in January of 40. The first lady that received the check, and I know this is in your PowerPoints, but I think it's just so interesting, was Ida Mae Fuller of Ludlow, Vermont. She was a legal secretary, and she paid in for 3 years, and the total amount that she paid in was like $24.75. Her first check was $22.54, and she lived to be 100. So paying in $24.75 over her lifespan till she died at 100, she got in monthly checks $22,888. Okay, and so the ratio of workers to beneficiaries has decreased substantially through the years. Now the baby boomers, not those born between 1947 1964, 1946 to 1964, that's the largest generation. They knew that this was coming, okay? And so there, currently is like 1 in 6 is 65 plus in the United States now. By the year 2030, it's going to be 1 in 4. So you can see where the disparity comes in there. So the number of workers paying in. So basically right now, some of you students who have jobs and are paying in, some of that money that you're paying in is going into grandma's check that she gets next month. It's sort of an in and out type thing, even though Social Security has really, the financial part of it has been bankrupt for a couple of years, but there's been some maneuvering with the federal government, and that's beyond the scope of this class. So anyway, I think I do allude to that in some of the PowerPoints. But the retirement age, 1937, was 65, okay? So then in 1938, okay, it started increasing by 2 months until the birth year of 1943, okay? So that meant that you had to be 66, okay? Then 1943 to 1955, the retirement age was 66. Then those people born 1955, it increased by birth year 2 months a year after that to 1960. So therefore, people born after 1960, the retirement age is 67 to get full retirement benefits with Social Security. Okay, so hopefully that gives you a little bit better understanding on that. Now I want to switch to the advanced directives. Many of you have already read that article. I encouraged you to share that with your parents, your grandparents. Some of you have responded that you did. That's not something that people like to talk about. I know my dad would never talk about it, but we did eventually do the estate planning with them and had the Medicaid in place, but fortunately never had to use it, okay? So again, a will, that is what you do with your possessions, what a person wants to happen to their possessions. If a person dies without a will, then it's called intestate, okay? So what happens to that person's property if they die without a will? Well, that's determined by the state that they live in, how it's dispersed, okay? A living will, also known as an advance directive. From that article you read, you can see that there's everything from a full code to a DNR. It is important for those of you that are going into the medical profession to know what a person has, especially if you're working rehab with them, inpatient rehab, or at a assisted living or a nursing facility, because many of them do have a DNR. And you have to make sure what their DNR says. You can still, with a DNR, do chest compressions. You can't be intubated, though, unless they specifically have, no chest compression. So it's important that you know. So what happens if you are a therapist and you're out there and you're working with a patient and they go into cardiac arrest and they have a DNR? You can't do anything. You just have to provide comfort care. Yes, activate EMS, but, just provide them comfort care. That's all you can do in a situation like that. So as far as those two things go, many times with a living will, a person will have a person that will be their medical proxy or their medical power of attorney. Now, there are usually two different types of medical power of attorney. There's one for financial issues, and then there's the medical power of attorney. Many times it's two separate people that have those. Sometimes if you're an only child, then you have everything. That's what I did with my parents. For instance, with my mother, when my dad died, I gave her usufruct of everything. But then whenever my mother became incapacitated, I did have her medical power of attorney, and I had to exercise that. I told you the sitters became quite expensive, and so we needed some additional money to help take care of her. So the house that she had moved in with me, but the house that she had was paid for. But I was able to take out a mortgage against that to use for her health care. And so I was able to enter into those legal agreements just as if she were entering into them. So that was the thing with that. But, with the medical power of attorney, many times that may be somebody outside the family. Even just the general power of attorney, that may be, outside the family as well. It just depends. It depends on what your family dynamics are. It depends on, who you're close to. A lot of jealousy can occur with that among siblings. There have been many situations where, siblings dispute over care, and it ends up costing their parent a lot of money to try and settle that. But the thing about power of attorney that's important to understand, that ends when a person dies. So that's why it's important that they have a will in place about their possessions. But let me go back for just a few moments. So the medical power of attorney. So a person has a living will. It pretty much spells out. But what about those decisions in the interim? Let's say a person has a stroke and they can't make those medical decisions for themselves. It's not a life or death matter, but let's say they're incapacitated, they're paralyzed, whatever the situation may be, they need somebody that can make those medical decisions for them. And so with that power of attorney, that person is going to act in that person's on that person's behalf with their best interest at heart, hopefully in that situation. I've read some places and I jotted some things down about who should you pick for your powers of attorney. Well, it should be somebody that lives nearby. It should be somebody that you consider trustworthy, someone who can be assertive, that can be your advocate with the medical professionals. Someone who has a certain understanding of the medical processes, is willing to can articulate, with the medical professionals, and then who has a willingness to serve. It also should be someone who knows what your medical conditions are, what medications you're taking, what allergies you have, who your doctors are, what insurance you have. It's not, it should be somebody that's just basically up on this stuff. And so that can be a family member. Many times it's a spouse. Many times it is a child. It could be a brother or sister. It could be, a family friend. And as I said, usually the person who has the financial power of attorney, that can be separate. But, if a person has the financial medical power of attorney, then the parent doesn't have to tell the person, doesn't have to tell everybody else who they've chosen as their agent. But that person with the financial power of attorney, they don't have the right to keep that parent from anybody else. Now, it's a little bit different with medical power of attorney, because that person, if they feel another person is detrimental to that person's health, they can keep that person, they can exercise that power of attorney and keep that person away from that person. So it's just some things to think about, especially with the finances and things like that. It's just, you just need to pick somebody that you can trust on all of that would act in your best behalf and carry out the wishes that you want. Okay, let's see. Have I covered everything? Gosh, I really do miss you guys. I wish we were in class. If there any questions that you have, feel free to send me an email or, send me a text about this. Like I said, I wanted you to have a basic understanding of all of this, because whether you're going into the medical profession or not, you're going to be dealing with aging parents, with aging grandparents, with siblings, with your spouse and yourself. And so, even patients that you may be dealing with if you're working in some other area of the healthcare field, not directly treating, that you can help them navigate these processes. Because just like I told you with that open enrollment, you would not believe the amount of material and phone calls that people over the age of 65 are inundated with. Just the Medicare book itself is about that thick. Okay. And then all these other companies are sending information. And so, you throw a little dementia in there, it can be very confusing to a lot of people, and they just don't know what to do. So anyway, I hope this has cleared up some of this for you. Might want to look for another video from me next week, maybe on some of the other topics that we're going to finish up the quarter with. But anyway, hope all of you are doing well. Stay home, stay safe. Bye.